On air.
Добрый день, уважаемые коллеги.
Good morning, dear colleagues. We are beginning our webinar in the framework of our Rare Disease Forum. It will be devoted to lysosomal storage disorders. There is a large group of disorders that has been in the focus of our attention for medical doctors, administrators, and for many diseases here, there are effective medicinal drugs developed. Therefore, the problems and access to solutions to treatment are topical for Russia and all other countries of the Commonwealth of Independent States. Of course, we are not considering all the diseases of this group today because it is hardly possible to do that in that short period of time. But we will focus on two major ones, that is the Fabry and the Gaucher disease. Of course, they have a larger prevalence, and in that term, they prevail over other diseases in this group. And I will speak about the Fabry disease in the Russian population, and Tareyev clinic under the Sechenov University has been focusing on it for a decade, and overall around 90% of adult patients with this disease have passed through us. What we have seen in our diseases reflects the situation that we have with that disease in this country. I will remind you that the reason of Fabry disease is GLE gene presence on X chromosome that codes the lysosome element galactosidase, and the shortage of this element results in glycosphingolipids storage in different tissues. First of all, nervous system, the heart, and the brain, as well as kidneys. In Russia, as of today, the diagnosis of Fabry disease is diagnosed around 350 patients, and 270 out of them have gone through our clinic. But of course, this number is much less than actual one. So the prevalence is 1 per 400,000 people. However, the real one, the real prevalence, would be 1 per every 50,000 or even larger. So a large number of patients with the Fabry disease is not identified. We have analyzed how Fabry disease is diagnosed in the patients that we have examined, and in less than every fifth patient, the disease was something that medical doctors thought of, and the main diagnosis was like family screening, that is screening the relatives, and what else we have had in Russia, that is screening in dialysis departments. So thousands of patients underwent this screening that resulted in identifying Fabry disease in over than 50 patients. So the majority of patients who diagnosed with Fabry disease in this country are those after dialysis and relatives, around 2/3 of the patients. Interestingly, who can believe that, who can think that Fabry disease is present. Very often it is manifested in the children's age, in childhood, but pediatricians do not often diagnose this in Russia or abroad, and very often it is identified by cardiologists or nephrologists. And we have not analyzed the percentage, but it is obvious that nephrologists and cardiologists are more tuned, so to say, to diagnose Fabry disease, and they can suspect this diagnosis. I will remind you of the typical manifestations. The first symptoms of the disease usually manifest in childhood or adolescence, and that includes neuropathic pain, that is really burning pain in the limbs provoked by physical load, stress, or fever. And I remember one of our patients that we received in our clinic in summer. It was very hot, and he was placed in the sunny part of the room in the department, and immediately he was experiencing really severe pain. So we moved him to the cooler and unsunny part. Another manifestation or symptom is angiokeratomas. That is a rash on the stomach. Around the umbilical cord part, and very often they are also located on the back and at the lower stomach, lower tummy, and apart from that, in the groin. So it is easy to overlook this symptom. If we talk about the organs, they are stricken by Fabry disease after the person is 20 or 30 years old. And first of all, what evolves and develops is the kidney disease, and in males it is more severe than in females. And as it is located on X chromosome for women, it is always in heterozygote position, which entails the disease to be characterized with easier nature. However, we do not doubt that women are healthy carriers. Very often we can see typical manifestations of Fabry disease in them as well. And sooner or later, the internal organs are subject to the disease as well. And there is usually proteinuria and the uh, lowered speed of the GFR, glomerular filtration rate. As I have said, in men, that is more, all of that is more manifested than in women. Here we can see comparison of patients who received treatment with hemodialysis. Two other organs that suffer Fabry disease is the heart and the brain. The heart, that is progressive hypertrophy of the left ventricular, that in men usually develops after 30, 40 years old, and in women a bit later, so that is around 50, 60 years old. And the second or third, if we remember kidneys as well, that is the brain. Around half of the patients has changes in MRI, focal changes, and it can also lead to stroke. Here you can see our data, almost 220 patients with Fabry disease, and the orange squares is the frequency of severe internal organs disorders, and mainly they were clinical disorders of organs in patients of younger age, and severeness grows. In this slide you can see chronic kidney disease of the third, fourth, and fifth stage. In the majority they are patients that had received hemodialysis or kidney transplantation, every fourth patients, and really severe heart disorders, stroke, ischemia. 7-10% of the patients account for that, and around 40% of patients at the moment of examination in our clinic had severe manifestations of Fabry disease, though the median age of those patients was around 40 years old. Here I would like to underscore the importance of early symptoms diagnostics of Fabry disease. It is clear that myocarditis hypertrophy patient is an example where we should exclude the most frequent manifestations, but these early symptoms are the key for diagnostics. And you can see that any Fabry disease phenotype patients can show these early symptoms, and we can suspect the diagnosis. Here you can see the percentage of treatment. Unfortunately, as of today, around 10% of the patients have died, and the median age medium at the moment of death was around 44 years old, so they die pretty early, mainly because of cardiovascular reasons, and usually they receive replacive kidney therapy. How can we confirm the Fabry disease diagnosis? Currently, we have all the diagnostics methods for Fabry disease well tuned in Russia. First of all, that is molecular genetic examination that enables us to identify genes, and then there is Lysosomal increased level and lowered activity of alpha galactosidase, and they are all the tests done in blood spots, mainly in Moscow, but in Russia there is a chance to send the delivery service sent through the delivery service these dry blood spots and have the tests done for free, both for the patients and for the medical institution. As for the role of histological examinations, in our opinion, if a medical doctor suspects Fabry disease, there is no need in histological diseases. It's much easier to send blood dry spots to confirm or exclude Fabry disease diagnosis. If the patient has already been diagnosed with Fabry disease, sometimes we have to do kidney biopsy, mainly when there is some discrepancy. For example, we had young female patients with around 4 or 5 proteinuria of almost nephratic type, though nephratic symptom is not characteristic for Fabry disease, but bearing in mind the age, we thought that there might be some other reasons. It is clear that Fabry disease can go with other diseases of kidneys, for example. So we had a biopsy done to exclude other reasons of nephropathy, but we did not see them, and it turned out to be Fabry disease nephropathy. And once again, I would like to underscore the importance of determination of Lysosomal. That is something that has important diagnostic value for both men and women, and this marker has certain diagnostic meaning, and globally there have been several studies and researches done. And here you can see one done by Albina Novak, our compatriot, with a group of authors. They looked into the role of Lysosomal as a predictor of unfavorable results. A very important significance is that of the family screening in Fabry disease, and as I have said, in Russia, that is one of the sources of patients with this disease identified. Here you can see our data, 83 provinces, over 600 relatives, half of them are something that we managed to examine. Sometimes the patients were unwilling to do that. In other times, we did not have contacts established with the relatives. However, we have examined over 300 relatives of the proband, and in 40% of them we identified Fabry disease. So it means two relatives per one proband. And in other countries abroad, this is usually five patients per one proband. So in Russia, we have a lower indicator. I don't know, maybe our families are not that large. However, there are families, like here, you can see the family tree of our patient with Fabry disease, and you see eight relatives of that patient identified with this disease. So, of course, examining relatives is really significant. And here we can first and foremost pay attention to the early symptoms and also the same types of lesions of internal organs. And for example, if one proband has a really very heavy lesion of kidneys, and the mother has a serious heart disorder, and that has to be taken into consideration when we gather the history of the disease. Another very important approach is selective screening. Here we can identify three risk groups: those patients who receive replacing kidney therapy, those with early strokes, and those with hypertrophy of the left ventricle. Every 100th patient can manifest Fabry disease. So we have to mandatorily test them for that, I believe. And the potential candidates, these are all the projects that have to be funded by someone. And in Russia, we had examination of patients who were receiving replacive kidney therapy. Of course, the costs are really high, but lower than newborns screening. Newborn screening in Russia is not taking place on a number of reasons. It is under discussion, but there are a lot of questions of ethical, first of all, nature. I will not stop on that now. As for the recommendations on enzyme replacement therapy in Russia, it is stipulated in the recommendations adopted in 2024, and a new version is pending because there is the third drug that has been made. And as for men, in our country, it is recommended to treat men right after Fabry disease is diagnosed because of the unfavorable flow of the disease. As for the women, of course, we have to first look at the signs of internal organs lesions and symptoms. If none, of course, what is recommended is just being observed. And according to our data, women also develop unfavorable results. But I would like to underscore again that it would be incorrect to consider them healthy carriers. Naturally, it is costly to treat Fabry disease, but bioanalogs give us additional opportunities. For example, in Russia, not long ago, we had an analog of another drug registered, and here you can see that it is a drug that has the full cycle of production in Russia. Here you can see the results of clinical trials. You can see the green curve, and the curves, the green and the gray one, practically overlap in terms of pharmacodynamics and other signs. In South Korea, there was a multi-central research to look into the safety and efficiency of Fabry with the patients of Fabry disease and dynamics of GB3 marker in transition from Fabraziv, the original drug, to Fabagal was under study. And we can see that the dynamics, the level of this marker after the transition, it either decreased or remained stable. That helps us understand that it is not less efficient than the original drug.
Now Russia is conducting favorite study where it studies different medicines for enzyme replacement therapy. And here we compare aglucidase alpha, alginal medication, algazine, and quite a big group of the patients were switched from subrazine to another drug. And as soon as we had the biosimilar, clearly the majority of the patients who before that received the original medication, so now they switched to the biosimilar. They're treated with this biosimilar. And by the way, here you could see different cohorts of the patients. Of course, the differences, and this is not a randomized trial, not a randomized study, which is conducted in the outpatient clinic. All the types of patients were taken for this trial that were available for the trial. That's why we have some differences. This trial is not over yet, and we are still, so I know that the patients are still recruited, and still the efficacy of the medication is also analyzed. We are analyzing the level of lyso-Gb3 level, and in the future we will assess the outcomes of the treatment. Here you could see the example. So there is no connection. The speaker could not be heard. So you could see here that the patients were moved to Fabagal, and then you could see that the initial level of markers reduced significantly, and then it was staged significantly. So you could see its dynamics in the patients in 4 groups. What is important? The red line is important for us. These are the patients that at first received the original drugs and then the biosimilar. Of course, we have some fluctuations and deviations, but in general, you could see that the median didn't change significantly. And this is in particular important when biosimilar impairs and the other biotechnical products, because they sometimes the doctors are quite cautious, but still these are the data that we have, and this data shows that the Fabagal in terms of efficacy and pharmacokinetics doesn't differ significantly from the original drug, and that's why we can broadly use it. And why this is more important? Because this drug is 40% less expensive than the original drug. That's why it could be introduced into the clinical practice and into the treatment of the patient. And this could be beneficial to treat the larger number of patients. Thank you so much for your attention. Well, we have the chat to this conference, and dear listeners, if you have any questions, feel free to ask these questions. So far, I do not Well, colleagues, and it's my pleasure to hand over to the next speaker. You could see the topic of the presentation: lysosomal storage disorders, enzyme replacement therapy, Gaucher disease, and the speaker is Jamila Shagilova, PhD in medicine, head of the neurology department, Republican Specialized Scientific and Practical Medical Center of Pediatrics, Republic of Kazakhstan or Uzbekistan. Good afternoon, dear colleagues. I would like to share our experience, our hands-on experience in the Republic of Uzbekistan. Gaucher disease is the most frequent form of the inherited enzymopathy, which is united in the group of lysosomal disorders, lysosomal storage disorders. We know that there are three types of Gaucher disease. The first type without the impairment of the central nervous system. The second type, the acute neuronopathic type. And the third type, chronic neuropathic type. What about the diagnosis? So here we take into account the clinical signs such as the physical development retardation, low weight, and low growth development, hepatosplenomegalia, and so we take the complete blood count, identify thrombocytopenia, anemia. We do the blood chemistry and determine the levels of markers. So under our supervision, we had 7 children starting from June 2023 with Gaucher disease. Now we have 15 children with Gaucher. In 15 children, and we observed 100% of anemia, and severe anemia was observed in 5 children. Thrombocytopenia in 80% of children, hepatomegalia 100% of children, and splenomegalia 60%. Splenectomy before admission to the hospital was already in 40% of children. Osteonic syndrome was observed in all children, bone pain 67%, and growth retardation, according to WHO, is also significant, especially in 12% or 80% of children, and 4 children had slightly reduced growth retardation. So we found Erlenmeyer deformities in 73%, seizures 27%, and eye movement dysfunction 67%. So now let's speak about the classification of children into different types. So 50% of children have the third type, and unfortunately our region has marriages within the families, and that's why we have children with such disorders. So the public foundation to support such children procured immunoglutarase. This is glurazim drug, which is produced by Generium, and this drug is used for treating Gaucher disease in children. Starting from June 2023, 7 children with Gaucher disease received this specific enzyme replacement therapy. Starting from 2025, 15 children received this enzyme replacement therapy. So you could see here the dose of the drug, and this was selected based on the weight and the type of the child and the type of the disease. This is the clinical case. The girl, Ifora, so she's born in 2019. This is the 4th child after the 6th pregnancy. So this is the child born in the family with a close marriage. So this was the term delivery, and then you could see all the signs of the disease onset. So the child has anemia, sepsis, hepatitis of unclear etiology. So the girl is asthenic and also has the signs of nutritional disbalance. We identified hepatosplenomegaly. So the liver was palpated under the lower edge of the rib curve, plus 5 centimeters. So convulsion. So we also observe convulsions, and the child is taking anti-convulsive therapy. As for the lab data, complete blood count identified the severe anemia, thrombocytopenia that was also confirmed by the analysis and diagnostics. As for the medical and genetic conclusion, we see the reduced activity of beta-glucocerebrosidase and significant increase of other enzymes. So starting from 2023, starting from June, the child received the therapy with glurazine medication 400 units. And against this background, in 1 month, we observed the improvement of the general condition of the child. So she gained weight, 300 grams, and improved her appetite, improved the sleeping. In 2 months, we observed the positive dynamics in the complete blood count. And then we also see the improved level of thrombocytes. As of March 2026, the child is 6 years old, 7 months, and her weight is 14.5 kilos. Hemoglobin 123 grams per liter, thrombocyte platelets 161 multiplied by 10 to the power of 9. This is the child before the treatment and after the treatment. So we could see quite good results. And this is the second clinical case. The name of the child is Odile Jaune. This is the first pregnancy, and the age of the child is 16 years old. The first signs of the child were observed when the child was 2 years old, and then we identified hepatosplenomegaly. So the spleen and the liver were increased. Complete blood count identified the severe degree of anemia, thrombocytopenia, and then we conducted splenectomy and diagnosed Gaucher disease. The activity of beta-glucocerebrosidase was significantly reduced, and the concentration of glycosyl sphingosine was increased. And after splenectomy in a year, the pain in bones increased. The child stopped walking, and at the age of 12 years, the child stopped walking. And the child had the shoulder fracture. In 2021, there was the second fracture of the knee joint. So we see this significant increase of the liver up to 10 centimeters. And so there is another. This is the same case, but now the child receives the enzyme replacement therapy with glurazine. You could see here the dosage 16 units, and we see that the child gained weight plus 4 kilos, and the liver size reduced by 3 centimeters. Hemoglobin is 116, platelets 354. Now the child is 19. He graduated from the school, and now he can drive the car after he received his driver's license. That's for the guaranteed the state medical and social support of children with orphan diseases. This is guaranteed by the order of the president. This order and this guaranteed support included 5 orphan diseases. So we also have the selective screening of 6 diseases: Pompe, Gaucher, Fabry, Niemann-Pick, mucopolysaccharidosis, and we can also perform the selective screening free of charge at the expense of the state. So, and finally, this is another decree, another governmental decree and the order of the president as of November 2025. And according to this decree, Gaucher and Pompe disease were included into the state program to make sure that patients are provided with the enzyme replacement therapy at the expense of the state. So it was also decided to increase the age of the patients, not from 18 to 21 years of age. To improve the life quality of the children with Gaucher disease, it's important to perform regular enzyme replacement therapy. Our practical experience in the Republic of Uzbekistan proved to be efficient, and we need to set up the register of Gaucher disease in Uzbekistan. We also need to conduct the selective screening of the patients and molecular genetic studies. I would like to thank you for your attention. So I see that you are limited by 2021, and I mean, the patients are limited by the age of 21 years old. And what to do with these patients after they all achieves this, after they achieve 21 years of age? They need the lifelong therapy, but we're happy, we're happy to have at least 21 year of age. We're going to continue working in this area, and we want to make sure that even adults can receive this treatment. And how old are your patients? The youngest is 1 year and 2 months. No, the eldest. I'm asking about the eldest. And I have 20-year-old patients. So soon this patient will lose all the treatment. So do you send your samples to the Center of Child Health? No, we have a special Republican center, a specialized center of pediatrics, where we conduct all analysis. No, I'm asking about Marcus. Maybe I misunderstood you. Okay, so I understand that you do everything in your centers. Well, when we started our work, these children were already came to us after being examined in Moscow, and now they come to us with this lysosomal storage disorders, and here we conduct the screening. As far as I understand, you are the head of neurological department, and Gaucher's disease is very often associated with the hematology. Well, everyone is asking this question, but given the fact that here we have children with the 3rd type, and we see the neurological picture as well. And we also have the team of the specialists, pediatricians, hematologists, and of course, hematologists help me. We have, this is the joint work. Okay, for the orphan disease, this is quite typical. especially when we start learning different diseases, there should be different specialists. In our regions, so we use the same approach. So thank you so much. It's very interesting.
Thank you very much, and let us proceed with the next presentation. Olga Mashukova, PhD in medicine, professor, head of the Department of Internal Diseases, Continuing Medical Education Research Institute of Cardiology and Internal Diseases. She will speak about experience in the diagnosis and management of adults with Fabry disease and other lysosomal storage disorders. Thank you very much, Mr. Maisev, for the chance to speak at this kind of forum. It is my first time, and it is my great honor to speak alongside you, Sergei Valentinovich, with your outstanding presentation that we have listened to. We knew that you would look more on clinical matters, and I would like to focus on the organization and methodological work of patient
Я выступаю с моим
pathways
содокладчиком,
of
мои
these patients with Fabry disease in Kazakhstan. And I have a co-reporter that is Ms. Mardulaeva. And today I would like to talk to you about historical landmarks and achievements in studying Fabry disease in Kazakhstan. In 2017, there was the health minister decree on certain matters of medical institutions with the Republican healthcare organizations and educational centers coordination. And the institute that I represent, R&D on cardiology and internal diseases, was appointed the coordination center on rare diseases of adult patients starting from 18 years old. And then in 2020, under the decree of the health minister, and that decree was really very significant strategically, and it is on adopting a list of rare diseases and their treatment. Apart from that, in 2021, Decree 75 was published on a list of medicinal drugs for guaranteed in hospital and outpatient treatment of patients and lysosomal storage diseases, including Fabry disease, was there, and glucosidase alpha and beta were among the drugs that were on the list. Our patients, both children and adults, are entitled to the guaranteed volume of free medical assistance. The main landmark of studying Fabry disease was the first case that we diagnosed in our R&D of cardiology in 2017. Starting from that moment onwards, educational events start, training events start, because we had no idea what Fabry disease was up to then. And I received patients with this phenotype, with a narrow forehead, wide eyebrows, and eyebrow arcs, and it reminds the phenotype described in Fabry disease, and you can see also the plump lips and rash that the doctors used to see as hemorrhagic rash, and there was inferior hearing abilities and lesions of intestine, and there was also hemorrhagic vasculite. And with this disease, medical doctors and hematologists, the first that they could suspect was hemorrhagic vasculite. And my colleague, a hematologist, sent this patient to me with that suspected diagnosis. When I saw it first, I had a preliminary diagnosis of another disease because there was proteinuria, and that was a polyarterinuria. It was preliminary diagnosis, but then when we had a chance to examine the patient better, we sent him to molecular tests, and the blood test had practically all the indicators within the norm, which was not characteristic for vascular. And when we received the results of the test, alpha galactosidase and substrate level were different. And we diagnosed Fabry disease in the classical way. And starting with this patient, the era of studying patients with Fabry disease began. And as of 2024, 720 patients were identified. And in 2024, the DTS type 45 patients were identified. I will not speak in detail of all our interesting cases, but like Sergei Valentinovich has said, the situation is similar. The largest number of selective screening in dialysis centers, neurological and cardiological departments is present. Then goes family screening, and the lowest detection is when the patients address us for assistance. In this time, we also have had a modest attempt to analyze the patient, and it was done in 2023. It is not a register, but we analyzed and clinically described the Fabry disease patients that went through cardiology R&D, and they were receiving ERT. So we published the results of this research. We described clinical cases in Russian journals and Vedic archives. We published our thesis there. So here we can see the number of publications. What is the legal framework for our organization of activities? We have a clinical protocol of diagnostics and treatment adopted by the Health Ministry in 2023, and that is a revision of the first protocol that was published in 2016. We're a team of experts, neurologists, cardiologists, rheumatologists took part in, and in 2026 the patients started accumulating, and we cannot even trace them because the diagnosis and identification is identified, and there is a huge work done in selective screening. So the health ministry has decided to systematize the work even better to trace the symptoms for enzyme replacement therapy prescription, because of course it is a costly therapy. So efficiency and well-groundedness were among our tasks. And in 2026, the decree at all regional levels, including that of the city of Almaty, was out. And it described the need to set up a multidisciplinary group to implement the roadmaps. And most importantly, the decree on appointing chief coordinators on rare diseases at all regional levels, including that on Fabry disease. So setting up interdisciplinary groups on excelling assistance to patients with rare diseases were also reflected in the decree, and in-person responsibility was also reflected there. So we have specific names, surnames of coordinators that are responsible for Fabry disease patient pathways. Currently, apart from organization and methods work, we also carry out researches and we initiated researches last year on arranging assistance to Fabry disease patients under the leadership of Sergei Valentinovich too, and we have elaborated an algorithm for general practitioners because according to our legal framework, receiving the drugs and dynamic observation and organization of the examination is the responsibility of general practitioners, the first chain doctors, because receiving the drug, ordering the drug, it all goes through this first stage. The general practitioners, therefore, their work has to be streamlined and there have to be clear cut action plans. And as there were a lot of questions that we received, we put forward this algorithm to general practitioners. And first of all, it includes suspecting Fabry disease by the first contact medical doctor. It can be general practitioner, therapist, cardiologist, nephrologist. So if the first contact medical doctor suspects Fabry disease, he or she sends the patients for biochemical analysis to determine days with the substrate, with dry blood spots tests, and the address of the lab is described in the hotline reviews, and we work on that. Coordinators work on that. So it is possible just to call the hotline and receive all the explanations. Then labs, including in vitro, carry out the tests. And it is all based on international cooperation. The test sample is taken for free. Then it is sent abroad to Turkish lab Gaucher. And if the result received is positive, this result is received by the first contact medical doctor, who afterwards sends the patient to the general practitioner, the first chain, so to say, doctor. According to our patient pathway algorithm, it happens like that. And then the patient is sent to all specialists, including that of genetics. Then interdisciplinary consilium is put together, but what is mandatory is the examination and prescription of the regional coordinator on orphan diseases, that is mine, and also examination and results of the examination made by the Republican coordinator, as we consult patients from all areas of Kazakhstan. They can approach us via telemedicine as well, via the general practitioner, and it is all done through our examination, and we look at all the tests and we look at their results, and therefore we make our own conclusions and include them into the doctor's report in terms of whether ERT is needed or additional examinations are needed. Of course, we have more opportunities than those at the regional level, and mostly to examine all the systems, cardiovascular system. The Republican level, of course, is higher than the regional. We try to have our patients referred to hospital to carry out a fully fledged examination. Then a regional level commission follows, and they again make their opinion for the Republican level to see whether ERT is needed. Then it is sent to the level of the polyclinic, and the polyclinic makes an order according to the decree 75 to have the drugs delivered. The first infusion is usually made in our R&D of cardiology, but if it is not possible, of course, we also train general practitioners to carry it out the outpatient clinic, and it all follows the protocol and diagnostics. And again, general practitioners afterwards monitor the efficiency of enzyme replacement therapy, and they can always address us in the Republican Center for consultation advice. We are always in touch with them. And afterwards, we refer patients to hospital at least once per year to assess the efficiency of the therapy. This simple algorithm for first contact doctors is in place. So what do they have to pay attention to is fever and gidros, fatigue, hypertrophic cardiomyopathy, joint syndrome, nephritic syndrome, hemodialysis. If any of these symptoms are identified, the first contact doctor should send the patient, should refer the patient to general practitioner, and then the general practitioner will refer them to neuro specialists. So they can also call the hotline here and get the necessary advice, and the delivery person can also deliver the map with the for the dry blood spot test. So the blood is delivered to the lab, and then we should wait for 2 to 4 weeks. And here you can see the algorithm of diagnostics of what experts the patient should go through, and what each neuro specialist should pay attention to while they are examining the patient diagnosed with Fabry disease, and what they should put into their medical history chart. So all these specialists, ophthalmologist, cardiologist, NT-E specialist, and when the patient is prescribed with algacidasa alpha and beta, and both drugs are present in decree 75, therefore we encounter no problems. But anyway, from 1 to 3 months is the time that they should wait for to receive these drugs, but they do it for free within the guaranteed scope of medical assistance. And then monitoring is carried out, monitoring of ERT efficiency. And again, once in every 6 months, the patient should consult these doctors and these specialists. And here we can see continuity and multidisciplinary approach to treating Fabry disease patients. Therefore, the clinical picture that Sergei Valentinovich described really very well is like this. Of course, diagnostics can be very long, and in a male, for example, that is usually late diagnostics on the backdrop of replacement kidney therapy, and there are neurological patients as well, patients with arrhythmia, with certain disorders in cardiological character. So diagnostics pose a lot of problems now, and we say still that Fabry disease is socially significant disease because complications and harm are those belonging to the cohort of neurological and other complications, and the first manifestations are of those socially significant importance. So why rheumatologists in our face, in the face of our doctors, deal with that? That is historically so happened from the moment of the first diagnosis of the patient.
Because Fabry disease, this is the disease with a broad spectrum of different signs. And we could see polyorganic manifestation, arthralgia, polyorgan diseases, and sometimes we do not have the joints damage, but still we have the rheumatological manifestations as well, such as juvenile arthritis and acute fever of unclear genesis. And rheumatologists are those specialists who should also examine the patients if we have such a patient, because we need to examine the patient correctly for the presence of biomarkers. And once again, I would like to say the sooner we diagnose the patient, the better quality of the life will be of the patient. And of course, we need a multidisciplinary team that will be involved in the diagnostics and the management of the patient with Fabry disease. So you could see here the pathway of the patients with Fabry disease. It's important to visualize the pathway of the patients. So here on the slide, you could see everything from the beginning till the end. So what are the tasks that we have and that we see? First of all, we see that we don't have the National Fabry Disease Register in the Republic of Kazakhstan. The number of patients is growing, and we need to coordinate all our specialists, because sometimes neurologists have their patients independently without the interaction with the nephrologist. Now we need the cooperation between the primary healthcare doctors and the Republican healthcare experts. We need such a coordination. And I also would like to discuss how other countries admit such patients to the hospitals. So we know that we have the patients with ICD-10 code E75.7, and we have difficulties with the admission of the patients with such a code because they're classified under endocrinology. And we try to find different ways to hospitalize the patients using other codes so that these patients could receive the necessary treatment. And in our center has rheumatological and pulmonological beds. This helps us a lot to treat these patients, to manage such patients. And if we see that patients have some syndromes, we can admit such patients to the hospital. So if Fabry disease is not included in the list of conditions eligible for inpatients or day hospitalization admission, this is our problem. And then we have adequate psychological support for patients. And during the recent years, we have identified the trend that the patients with mucopolysaccharidosis are more active, and we do not see the same public activity of our patients, and we don't see a very active social life of Fabry patients. So they do not want to disclose their disease. They are quite discreet, but at the same time, they also need the psychological support. and then we send them individually for psychotherapeutical support and consultation. Of course, we need to raise the awareness about the Fabry disease, regular monitoring, and also the setup of the patient registry. We also need to improve the case detection at the primary care level and conduct family screening. So thank you so much for your attention, dear colleagues, and apologies if I have taken too much time. Well, thank you so much for your interesting presentation. Well, as for the codes, well, there are many different rare diseases or orphan diseases that are differently treated, I mean, in terms of the codes. And may I ask you a question? Where do you perform the infusions? So is it in the outpatient clinic or should the patient be hospitalized? So we have already worked in this area, and all the patients who are diagnosed, they attend us in our using the telemedicine. The first infusion is performed in our department. So there is no recommendation for pre-medication, but we also had the cases of side effects or undesired reactions. That's why we try to do the first infusion in the clinic. Then we use antihistamines, dexamethasone, and in some regions, the doctors are afraid of performing these infusions, and everything what is related to the gene therapy is quite scary for the doctors. That's why they send these patients to us. And if we see that patient tolerates the drug quite well, then they can receive this infusion in their hospitals, in their outpatient clinics. We have special rooms of or departments of gene engineering therapy. So the patients could go there at the place where they live. So usually we train the healthcare providers. So we're trying to find a way out. Everything is quite well established already. We're always in touch with the patients. So do you give this drug to the patient or do you hand it over to the outpatient clinic? Well, usually this is the outpatient clinic which procures the drug, and then this outpatient clinic gives the drug to the patient. Okay, so the patient comes to you and takes the drug. Yes. So you see, everything is important here, not only the technique that we use to perform the infusion. We explain to the patients how to keep the drug, how to store it. We train them as well, because this is another important fact. They should not be kept in the freezer or in the balcony or somewhere else. So the transportation should be very careful. And then every 2 weeks, the patient receives this infusion. I do all the calculations, how many vials the patient needs, depending on the weight or the change of the body weight of the patient. The patient brings his 3 or 5 vials to the outpatient clinic or to the treatment room for the infusion. Okay, thank you so much. So let's proceed. And we have the next speaker. I would like to hand over to Chris Worster from the Northwest University. And he will tell us about the lysosomal storage disorders in Africa. Chris, you're welcome.
Thank you very much. Just confirm that you can see my screen.
Not yet. This is the previous presentation. These are the previous slides.
Okay, how about now?
Yes.
Okay, thank you very much, colleagues. My name is Chris Foster. I am the director of the Center for Human Metabolomics in South Africa. Thank you for the opportunity to share with you the work that we are doing in rare diseases and then also in lysosomal storage diseases in particular. So just by means of introduction, the Center for Human Metabolomics is in the Northwest University, which is about an hour and a half's drive from Johannesburg. We also host the National Metabolomics Platform, and our activities includes diagnostics for inherited metabolic diseases, newborn screening, metabolomics analysis for other research groups within South Africa, then point of care testing development using our gold nanostars, rare diseases biobank, UNGWE, which is our rare undiagnosed diseases program. And then pretty soon we're also going to add a treatment development unit to our program. So just also what's important in terms of this presentation, our center does quite a bit of training and development. So this is our continuous professional development program. Some statistics from last year, you can see that we've got quite a far reach within Africa, also the Middle East, India, and then also North America, but noticeably no participation from Russia. Maybe that will change. And then we've also got specific outreach programs within Africa. This is the Africa Network. Here we bring clinicians from Africa to our center for a week-long, very intense training. And it has been a very fruitful endeavor. Typically, after we have trained them, we also enable them to do testing specifically for lysosomal storage diseases, because this is the one test that we currently offer on dried blood spots. And yes, it's been very fruitful, as you'll see as my presentation proceeds. Okay, so this is what it's really about. This is the burden of rare diseases. You can see that in South Africa, we estimate that there's about 3 million patients that are affected by rare diseases. This is some statistics that was done by Professor Helen Malherbe from our institution, not yet published, but it should be published quite soon. And of course, if you're not aware of this burden, these patients still make it into the healthcare system, and they consume a disproportionately large share of the total healthcare budget. Whereas once a diagnosis is made, then if there's treatment, that treatment can be initiated, but one can also design appropriate care, patient counseling, family testing, and then also destigmatization and other examples, as well as planning, both for the family as well as for the healthcare industry. And of course, diagnostics is the gateway to all of these things. So just moving on to our lysosomal storage diseases program. Lysosomal storage diseases is a group of about 70 conditions that affects the function of the lysosome. And they're almost 150 years old now. So Tay-Sachs was the first lysosomal storage disease diagnosed. That was in 1881, and that was followed by Gaucher disease in 1882. And what I'm showing you at the right here is just the degradation of the sphingolipids, and some of these have already been mentioned by some of the previous speakers, but what you can see from my slide is degradation of sphingolipids requires a number of enzymes, and when these enzymes are defective, then some of these diseases that have already been mentioned result. So for example, here's Fabry disease that has been mentioned, and there's Gaucher disease that has also been mentioned. Also, very importantly, when the enzyme is defective, then typically the substrate of that enzyme will accumulate. So in this case here, it's glucosylceramide, which is the substrate for acid beta-glucosidase, the enzyme deficient in Gaucher disease. And then as a result of that, it's deacetylated to form, in this case, glucosylsphingosine. So what happens in effect, it loses a hydrocarbon chain. And because of this loss, the metabolite becomes more water soluble, and now we can measure it in blood and urine. So this is the degradation pathway for sphingolipids, but there's also a pathway for glycosaminoglycans, oligosaccharides, and so on. Many of these patients are normal at birth, and then after an initial symptom-free period, they start to deteriorate. There's usually no intermittent fluctuations, so normally it's progressive deterioration, often affecting the central nervous system, the liver and the spleen, bone, and also other systems. And although we diagnosed these conditions prior to 2017, we really got involved at the beginning of 2017. We were initially approached by Sanofi to set up testing for some of the diseases that they, of course, had treatments for. And it's actually been one of the most successful endeavors of my professional career. So in our laboratory, this is our approach to the various lysosomal storage disorders. We're not able to diagnose them all, but essentially we have 3 tests that we use. The first is the 6-plex LSD, which is basically just an enzyme test that includes 6 enzymes, and this is Gaucher, Niemann-Pick A and B, Pompe, Fabry, and then mucopolysaccharidosis type 1, and Fabry, sorry, I don't include Fabry. And then we've got oligosaccharide analysis on urine and glycosaminoglycan analysis also on urine. And this actually enables us to test for quite a large number of the lysosomal storage diseases. This is the typical workflow in our laboratory. So we've heard a lot about dried blood spots. This is most certainly the way to go in Africa, where sample transportation can be very difficult. Although enzymes on the dried blood spots is not completely stable, it's typically a lot more stable than in ordinary samples. And we are currently actually in the process of moving most of our methods to dried blood spots and even dried urine spots, which we think is the way to go in Africa. So the workflow is something along these lines. It doesn't happen exactly like this, but it will give you an idea. If we do get a request to work up a patient for a lysosomal storage disease, we would typically start with the 6-plex LSD test. If the test is positive, then we will do the appropriate genetic testing. So for Fabry, Gaucher, and MPS. And if any of those is positive, we will also do the appropriate markers. So we've heard about lyso-GL3 or lyso-GB3, lyso-GL1, and then for MPS1, the urinary glycosaminoglycans. These are, of course, important for monitoring purposes. If the test is negative, we'll look at the initial request. If it was for Fabry, we'll go on to do lyso-GL3. We've already heard the importance of really multi-marker testing in Fabry disease because it can be difficult to diagnose these patients. If MPS was requested, then we will go on and do expanded MPS testing, including a number of additional enzymes, as well as urinary glycosaminoglycans and sometimes oligosaccharides. For example, if one would expect alpha-mannose, which can present very similar to the MPS conditions. And then if Gaucher was suspected but is negative, we'll go on to do lyso-GL1. And anyway, just for possible supposed C deficiency, although up to now we haven't diagnosed one. So it's been a very fruitful program, and since from the period 2019 to 2024, which I'm showing here, we've diagnosed a lot of patients, as one can expect. Gaucher disease is what we diagnosed the most, but quite interestingly, mucopolysaccharidosis type 2 is very common in South Africa and in Africa, and I do foresee that in time it will eventually overtake Gaucher disease. And then I've also listed some of the other patients that we've diagnosed. Yeah, like I say, it has been a very fruitful endeavor. Now, one thing that is very important is the dried blood spots. As I've already mentioned, this simplifies logistics quite a bit, but the enzymes is not completely stable. Now, I don't have data on the lysosomal enzymes, but what I do have data on is biotinidase deficiency or biotinidase, and then galactose 1-phosphate uridyl transferase, which is 2 enzymes that we use in our newborn screening program. And as you can see, over a period of 7 days from collection, biotinidase will decrease by about almost 20%, whereas GALT will decrease to as much as 30%. On the other hand, if you measure the biomarker, the substrate, in this case galactose 1-phosphate, which is the substrate for GALT, you can see that it's stable as a rock. And measuring substrates certainly also do have some disadvantages. But we do foresee that this is the way to go in South Africa and Africa. So in our future approaches, what we would very much like to do is to measure metabolites or substrates as an initial screening test, and then to proceed straight to genetics. And then in complex cases, we may have to do the enzyme analysis as well. Pompe is the exception at this stage because the measurement of the substrate is quite difficult. So we may remain with the enzyme analysis in Pompe, but the other diseases we certainly want to move to metabolites and substrates. Yeah, I'm just showing you some data from our African outreach program. And it's also a theme that has already been mentioned, but what is very important is that we don't just look at the laboratory diagnostic accuracy, sensitivity, specificity, and the number of patients that we've diagnosed, but we really need to look at the entire value chain. So, for example, in this publication, which you can just get from the internet and read by yourself at some stage if you're interested in it, we've also, for example, here looked at the number of days it takes the sample to reach the laboratory, and you can see that in some countries this can be quite severe. And of course, this is an area for improvement, and we have to come up with ways in which we can improve that, seeing as that we know that these enzymes do degrade over time. And like this, there are many other things to monitor: access, equity, etc., and so on. And we'll touch on some of this as I continue along with the presentation. So as I continue with my presentation, you'll see that a central theme is that I think that the laboratory should take responsibility for a lot more in the total management care of patients, and not just the laboratory data, because the laboratory is a place where data accumulates, and that data is very valuable and can be used for patient care, real-world evidence, etc., and so on. So in a proper analytical framework, the laboratory should be measuring the demand for a particular request. You know, if the laboratory knows the demand should be higher, then it should offer the necessary education and training. Of course, then the traditional things, the quality, the diagnostic rate, and so on. But then equity, also ensuring that patients do have access to the test, as well as the treating clinicians and so on. And then monitoring of the outcome, you know, the number of patients diagnosed, whether initiated on treatment, the monitoring of the patients, and also family cascade screening if that is required. Okay, so just to go into a little bit more clinical details. So here's just an example of a case, of an African case. This was a dried blood spot that we received from a 1-year-old with hypertonia, hepatosplenomegaly, and anemia. And initially, when sample reception showed me the score, I actually wanted to reject it. It seemed to me that there was an obvious collection error here. Maybe the sample was collected very close to the intravenous line or something along that line. It seems to be contaminated with some kind of fluid. And then the clinician phoned me and told me to please analyze the sample. The patient had passed away, and that wasn't collected from an intravenous limb. So we went on to do the analysis, and this is actually the extent of anemia in this patient. And so as you can see very clearly, acid beta-glucosidase is decrease, and then severe increase in lyso-GL1. And then when you do the genetics, you find that the patient had 2 very complex recombination variants that results in severe disease. There's also various tools that one can use in the laboratory for decision support, and this will become important as we start to transfer the knowledge that's currently in our laboratory to partner laboratories within Africa. So this simplifies interpretation quite a bit. So here I'm using CLEAR, which is a tool that was developed by the Mayo Clinic that enables you, for example, in this case, if I'm unsure if this is a case of Gaucher disease versus artifacts, which is very often the case in Africa, and the tool clearly helps me to separate the true cases from the artifacts, and that will limit the amount of sequencing that I need to do to confirm the diagnosis. Okay, a little bit about Fabry disease. We've already heard a lot about it. Perhaps one thing that I would want to mention is that our African colleagues are clinically extremely strong. So, you know, when we do this focus training within our center and we have African clinicians visiting us, then usually their baseline knowledge is already at a very, very high level. And that's perhaps because of a lack of infrastructure, so that one has to rely more on clinical skills. So that's an important point to keep in mind. So if we receive an LSD test from South Africa, our diagnostic rate is about 4%, whereas if we receive it from some African countries, it can be as high as 25%. Fabry disease, of course, can be quite complex or quite difficult to diagnose initially, particularly if the symptoms is not severe. So often it can be misdiagnosed as irritable bowel syndrome, fibromyalgia, depression, and so on. And it is important to be aware of those clinical polls that's going to assist you to make the diagnosis. So in the eye of this patient, you can clearly see the clinical phenomenon known as cornea verticillata. And there's only two other things that can cause this, and that's amiodarone treatment, which is unlikely in our patients, but then unfortunately also quinine, which is used quite often in Africa. So it's not foolproof, but it's certainly a great aid in making a diagnosis. The other thing where we have to provide training and ensure that our clinicians is up to speed is with the genetic aspects of the disease. Again, this has already been mentioned. But, you know, a genetic counselor is almost non-existing in South Africa and Africa. So our clinicians need to be skilled in the genetics as well. And I'm just showing you some pedigrees here. And at first glance, you may think that this is actually an autosomal dominant disease because you find affected individuals in every generation. But in fact, this is Fabry disease. And this is what happens when male patients are fertile and that they can then produce offsprings. And the clue here is to find male-to-male transmission. So if there's no male-to-male transmission, then you know that it's an X-linked disorder, because an affected male cannot pass his abnormal X chromosome on to his to his sons. He can only pass his Y chromosome. So you look for male-to-male transmission, and that's not there, then you know that it's an X-linked disorder, and that may be quite important in cases like Fabry disease. It's much easier if male patients are not fertile. Then another thing that we've mentioned is the phenomenon of skewed X inactivation. So in female patients, one of the X chromosomes are typically inactivated. And if the inactivation is very skewed, in other words, that most of the inactivated X chromosomes are normal X chromosomes, then females can also end up having Fabry disease. And it can create quite interesting phenotypes. So for example, you know, you may have a patient where only some of the biomarkers is positive. You may have a patient that develops Fabry disease in only one organ. So you've only got Fabry disease in the heart or in the kidney. And so what we usually say with our female patients is if you suspect the diagnosis, but you can't make it, then one, try another biomarker, two, try another organ, and then three, try another family member that may have the disease, particularly if there's a male family member. So these are all things that our clinicians need to be aware of because of the lack of other resources that is typically available on the first world. Okay, moving on to treatment. As I've already alluded to the fact that there are many barriers to finally getting a patient onto treatment. So education and training is, of course, a barrier. And then there is the associated logistics, the harsh temperatures and geographics of Africa, the diagnosis. There are many pitfalls that you need to be aware of. But then finally, if you do have the diagnosis, then it is also quite challenging to get the patients on treatment in Africa because of the cost. But we are more and more successful, relying a lot, of course, on compassionate programs. But in some instances, also governments have started to reimburse the treatment of rare diseases, and in particularly lysosomal storage diseases and enzyme replacement therapy. An important thing that also came from the work that Professor Malherbe did is that of all the rare diseases, there's only about 5% that requires expensive therapies. So, you know, it's really important that we do those economic assessments and make sure that we provide the best possible care for our patients with consideration of the entire healthcare system. Okay, so where do we see the future in South Africa and Africa with regards to lysosomal storage diseases, but then also rare diseases? So as a start, we need standardized referral forms. Our view is that the geographics and the logistics in Africa is just too difficult to have centers of excellence. So we're looking at a model where centers of excellence is virtual, where they actually outsource the services to clinicians who then sees the patients and are reimbursed when they return the information. And this is not a new model. It's actually something that is being adopted in many countries in the newborn screening programs. The problem in newborn screening is the diagnosis gets made and then the patient is lost, and there's no real world evidence with regards to the outcome of making the diagnosis and the treatment. So what many countries are now doing is they're changing, if I can call it, ownership of the patient. So if the newborn screening laboratory diagnoses a patient, the patient remains the patient of the laboratory and not of a particular clinician, and the laboratory then outsource the clinical services to the clinicians in the laboratory. Almost becomes the director of the whole multidisciplinary care process. Make sure that the patient consults the correct specialist, make sure that all the data is centralized, and then that there can be joint case review and assurance of access and equity. And these are the things that we think is going to be very important in the future of rare diseases in South Africa and Africa. There are various ways in which the laboratory can support our clinicians. So, for example, here on the right is just our WhatsApp group, and we've managed to sort out many patients in Africa just by a simple WhatsApp group. So this is also basically an example of a virtual center of excellence. So in my ideal rare disease managed care world, we have a rare disease advisory committee, which is what we're currently actually establishing. And under the Rare Disease Advisory Committee, we've got various centers of excellence, and these are virtual centers of excellence. The advisory committee designs policy, procedure, and governance, and these centers of excellence are then focused on particular groupings of patients within rare diseases. So there may be a center of excellence for lysosomal storage diseases. If you think about it, it's in most instances, a rare disease patient or a lysosomal storage disease patient, let's just take Gaucher as an example, don't actually need an expert during a consultation. You don't need to be an expert to collect the phenotype when you consult the patient. So in a Gaucher patient, this is going to be the extent of hepatosplenomegaly, some basic laboratory testing like a full blood count, maybe some radiology, maybe a bit of a consultation with regards to bone pain and other bone pathologies and so on. This is not the difficult part. The difficult part is the decision-making that must result from this collected information. And this is what we see where the role is of these virtual centers of excellence, so that they ensure that there's collaborative decision-making, but there's also equity and accountability across the decision-making process. And this is the way in which we would like to take this forward. It also puts us in a position where we can collect real-world evidence, and that evidence can then inform future management of patients and appropriate decision-making. So our advisory board and our virtual centers of excellence would almost be like directors of a company, whereas the laboratory then becomes the executive officer, making sure that the strategy is implemented, making sure that the patients get the necessary clinical care, make sure that the data are centralized, become available for decision-making, and then inform future decision-making and access to care and management. So I'm going to leave you with that, and I'm happy to take some questions. Thank you very much.
Thank you very much. Though we do not have much time left, let me look at the questions. I would like first to comment on what you have said. Sure, there might be differences in medical care systems because experience of Russia, Uzbekistan, and Kazakhstan is like a lab does not have that leading role or position that you are mentioning. Of course, if we talk about genetics, genetic labs give really significant assistance and they are of great value. Another moment, Professor Worster mentioned that clinicians have to have knowledge in genetics. Well, first, I believe that general practitioners will hardly be able to have that. However, we all have seen family trees. I believe it is really important to understand that, because some minimum is something that any practitioner, any general practitioner can make advice on in terms of who, for example, can inherit Fabry disease. so it was not translated correctly about Fabry disease with the male-to-male transition. It is clear that those men can have children, but they do not, the sons do not inherit Fabry disease. And as for screening, in Kazakhstan, we heard there are no patient organizations that deal with this matter. And whereas in Russia, there are a lot of patient organizations on various diseases. And I believe that if in Kazakhstan there are none, you have to just invest certain effort into that because among patients, of course, there will be active ones or parents, and they can come up with that organization to provide assistance to other patients. So I have not received any other questions. Therefore, let us proceed with our last presentation. Raushan Matusheva, PhD in medicine, head of the Department of Hematology, National Center for Maternal and Child Health under the Ministry of Health of the Kyrgyz Republic. She's going to speak about experience of Gaucher disease and experience of Kyrgyz Republic. Over to you. Good afternoon, dear participants of the conference. I would like to share with you early diagnostics of Gaucher disease experience in the Kyrgyz Republic. Gaucher disease is the most widespread inherited pathology of lysosomal storage disease group, like has been said. It is accounted for by GBA1 gene mutation, and it can be present in three types. So the first one accounts for 95% of cases and is manifested in hepatosplenomegaly, cytopenia, and skeleton lesions. The second type is the severest central neural system lesions, and the third one is well known. And as for red markers here, we can see the red flags, clinical red flags, that is a critical increase of spleen, then cytopenia and bone pains with deformation. And laboratory gold standard is DBS to determine activity of beta glucocerebrosidase in dried blood cell, as well as Lyso-GB1 target biomarker that enables to control the therapy. DBS and Lyso-GB1 biomarkers are modern gold standards of early verification and diagnosis. A modern algorithm of verification is as follows. That is DBS screening to determine the enzyme activity, Lyso-GB1 biomarker to determine the quantitative level of substrate accumulation, GBA1 genetics to sequence for mutation. And as of now, in the Republic of Kyrgyzstan, we have officially registered and verified 6 patients with Gaucher disease diagnosed, and all the diagnoses were made beyond Kyrgyzstan and Russia, India, and Turkey. And it confirms the status of disease as ultra rare, and it demands centralized experience and resources in specialized hematology centers. And screening is the key method. Screening in risk groups is the key method to identify it. Here I would like to share with you a clinical case of a patient, Azalia Razieva. The first examination was in July 2024 in a national center named after Rogachev. And the first examination of the stomach organs showed splenomegalia. The spleen was increased to 128 by 48 millimeters.
Here on the milligram, we identified also Gaucher cells, and the majority of them were damaged. So we conducted also DBS, and we saw the reduced activity of the enzymes of the beta-glucocerebrosidase down to 0.61. So we administered the treatment of the patient based on the enzymatic test, and we saw the deficit of enzyme activity, and we also conducted cytology of myelograms. The patient was diagnosed with Gaucher disease first type, ICD-10 E75.2, and the patient was administered the treatment. This is the same patient who came to Russia 3 times. You could see here the treatment changes and the improvement. So you could see that the spleen on the ultrasound shows reduction. We saw the normalized or in the improvement of the level of platelets, hemoglobin, and LGD. So 6 months before the situation was different, so we managed to adjust the dose of the patient. The patient receives 800 units, 45 units per kilo, twice a month. So we have analyzed the genetic status of the patient and the family status of the patient. So the mother and the father of the patient were the carriers, asymptomatic carriers of this disease. And as for the siblings, one sibling is completely healthy, and the second sibling is the carrier. So all these studies confirm that this patient has the gene mutation in the current population. Now let's speak with you about the orphan initiatives. All in all, we have 6 patients, and we don't have lots of experience, but it will be great if we establish the unified register of such patients, because this will help us to work using the Ministry of Healthcare guidelines. So then the dried blood spot enzyme assay is also should be used as the routine assay in children of the high risk group. These can help us to improve the diagnosis and also to improve the enzyme replacement therapy. So what about the conclusions of my presentation? We need to be very cautious, and every case should be examined thoroughly. If we have some isolated cases of splenomegaly, so we need to suspect the Gaucher disease. As for the efficiency of the enzyme replacement therapy, we have already saw the importance of such treatment. So this is the major conclusion. Thank you so much. Well, I have only one question. Do you provide the patients? So you mentioned you have 6, 7 patients, and all of them receive the medications at the expense of the state. Am I right in understanding? Is it so? So 3 patients received the drugs from Russia as part of the humanitarian aid. And we will also apply to the Ministry of Healthcare, to the Foundation of High Technologies, to receive such products free of charge, such medications free of charge. Okay. So as far as I understand, only the companies provide the drugs to the patients. And what about the lysosomal storage disorders? Is the situation the same? Say you've mentioned Fabry disease, and do you treat it in Kyrgyzstan, or you do not deal with this disease? Well, we have only one case of Fabry disease. As for Pompe disease, we also have one case. And Gaucher disease, we have 6 patients with Gaucher disease in our department of hematology. And we also had some children, just 2 children of the second Gaucher type 2. They are siblings. So they were admitted to the hospital and then they moved to India for further diagnostics. So, and they were diagnosed with Gaucher type 2. We haven't seen them anymore. And do you conduct diagnostics or do you send samples somewhere? Well, all our 6 patients, were sent to foreign labs because we don't have such labs. And I remember that in 2019 we sent the test to India and then to Russia, Turkey, and our recent experience is that we send the dried blood spot enzymes to Russia for the assay in Russia. And why India? Because this family found a sponsor, and the sponsor suggested sending to the Indian lab because we don't send to India. Okay, this is clear. Thank you so much. I don't see any questions in our chat, but in any case, I think that our discussion is quite interesting. And in general, the topic is interesting. Well, undoubtedly, these are often diseases, but the number of the patient is growing progressively, especially when we start diagnosing them. Of course, we have some challenges with diagnostics and the therapy and the treatment, but still we can address the challenges. As for the joint registers across the CIS, I don't know whether this is achievable because even in Russia we cannot establish any register. Even we have the problems. But it seems to me that it's more important to identify some centers that are not numerous, but as for Gaucher disease, we have one main center that treats Pompe and Gaucher disease. Well, I know that there are not so many institutions that can treat such diseases, but still we can ensure the direct experience exchange and best practices exchange. Well, in Russia, as we have quite a well-aligned treatment and streamlined treatment of Pompe disease and Gaucher disease. I would recommend you sending the assays the tests to Russia. We have the genetic specialists who can help you to identify some mutations. And by the way, there are some mutations that are not so important for identifying the diseases, but clinicians have lots of questions. But the experienced geneticist who understands everything very well can help you to interpret everything correctly and different genes correctly. We always resort to the geneticist in diagnosing. Well, of course, sometimes we leave the diagnosis of some genetic disorders that are diagnosed by other doctors using some doubtful genetic mutations, especially when we don't have the clear clinical picture. I remember that the patients received a very high, very expensive treatment, but the diagnosis was not confirmed in the end. Okay, but In any case, we need cooperation in this area, and this will be beneficial for all the countries, especially for our patients. So now I believe we can conclude our session. It's okay that we will finish 5 minutes early. At least you will have the chance to have more free